So today we're going to do This Is How We Do It from Geisinger on crisis management related to our facilitated discussion last week. We really wanted Geisinger to do this because not only do they do a lot of it for a long time, but they're super efficient in how they do that. And that's why I think it's going to be really great to have them talk. They're used to just stepping out and doing a visit and doing a quick warm handoff, 10-15 minutes, and having a really strong safety plan done. So I'm excited to learn from Jess and the Geisinger crew about how they do that today. And then Rachel can't be here today, but she sent us a really fantastic research corner. So I'll quickly go over the research corner, and then we'll have a discussion related to costs. So cost conservation and how telehealth impacts cost, and whether anybody in the group has done any kind of cost analyses or thinking about that within their own organization. And then lastly, it might be good to just quickly touch base again, Jess, with our kind of inter-organizational collaboration between Division 54 and us. I think we've all kind of put it on pause just with things going on and leaves and stuff like that. But it might be good to just right before we leave, check in on that and set an agenda moving forward about what's best to do with that. So that's kind of our agenda today. If you have jobs, as usual, put them in the chat. If you have topics you want us to discuss for facilitated discussions or other things, please put those in the chat as well. Yeah, Jess, do you want to go first? You want to kick us off with This Is How We Do It?
Surely. I'm going to try to share my screen here. Let's see what happens.
Yes.
Okay, perfect. Okay. So before I get started, so this is not going to be a presentation on doing full crisis evaluations in primary care. This is just how do we do this in the context of a warm handoff. So here at Geisinger, we have a lot of strong research and experience doing crisis evaluations within primary care with the goal of trying to do as many like ED saves as possible. Certainly there's a financial benefit to that, but more importantly, a lot of kiddos aren't getting necessarily the best care sitting in the emergency room. Sometimes kids might get sent home with a subpar safety plan. And we just have, as clinicians and PCPs, we just have a little bit less control when they go to the ED. And depending on if they're in network hospital, so in-house at Geisinger, or a hospital outside of our system, sometimes we don't even know the outcome. And so we find it really important to be able to do these crisis appointments within primary care as our first step in a warm handoff to determining if a full crisis evaluation is needed, and to help make sure that those kiddos are going home with a good safety plan and urgent follow-up as needed. So with the slides I'm about to present to you, I can't take credit for all of them. These are our in-house Geisinger training slides that we use for our learners. We use for doc talks, grand rounds, etc. So this is, I can't take credit for any of the slides, but I want to share some of the content that we have that's, been shaped up by our learning team here. All right, so why is it important? Why else is it important to talk about suicide in primary care? Usually our PCPs are the first point of contact. I think you all probably see that, especially with including the PHQ-9 in screening for well child visits. That's gonna, increase the likelihood that we can identify these safety concerns early on. We also know that with PCPs, they have so much training that their time, I think they get maybe a few months in psychiatric care as part of their residencies and medical school training. And so when it comes to identifying someone who's high risk with not as much training, that's going to increase a high stress situation, especially when PCPs have limited times per patient, and could increase the chance for mistakes or even missed opportunities to help intervene with a kiddo that needs support. So our hope is that by having us on site, we can help support our medical colleagues in kind of taking, the baton and helping to screen and develop a plan for these kids. All right, so when you get a warm handoff, often, here at Geisinger, we're often roped into a warm handoff, SI screen when the PHQ-9, that 9th item that talks about SI is flagged. However, there's times that kids will come in, as an acute visit just for behavioral health reasons. Even though we try to scrub schedules and try to get those kids off our PCP schedules, certainly they come through. It can happen if a kiddo is there for some other type of concern, maybe even a med management visit, and part of the PCP's assessment might identify suicidality. So So, we want to make sure that we communicate to our PCPs and our medical partners, as well as to our behavioral health teams, to take all of these threats seriously. If we suspect something's going on, simply asking and being really clear and concise with how we ask. In a few slides, I'll put some items on the screens as just questions or prompts that you can ask to be really direct. One of the red flags that I look for is if a kid pauses, hesitates, maybe moves eye contact away from you, hedges a little bit, then I might think about the environment that kiddo is being asked those questions. Perhaps I'm going to review limits of confidentiality and have the caregiver step out and perhaps ask those questions again, maybe even a different way. So while you're in the room for a warm handoff, you're kind of observing, how is kiddo behaving? How are parents behaving? What did the PCP, how has the PCP talked about it already? You want to get a sense, how are they doing that day? Are there any somatic concerns? Are they feeling dysregulated at all? And of course, any big stressors that have gone on recently for that kiddo. So any difficulties socially adjusting, especially with COVID the last year, kids have been in and out of in-person school. It's been hard to stay connected with friends. And of course, any previous suicidal behaviors. These are all red flags that we want to consider as we're doing this very brief assessment. So some of these you're going to observe yourself while you're in that warm handoff, and some of these we might even be able to get from our physician partners before we step into the room. Any questions or concerns so far before I move on to the next slide? Okay, all right. Okay, so when you're called in for a warm handoff and the concern about safety pops up, I think there's a couple different ways that you can do this. But if you have access to the Columbia Suicide Severity Rating Scale, or at least familiar with those items in your head, I feel like this is a really good place to start, especially because it hones in just on suicidal ideation, and it helps get a sense of, how often do these thoughts occur? Have you ever actually thought of killing yourself? It helps to identify any means, intent, and plan as well. So if you have access to this, I definitely say in that warm handoff, follow up with that, because that's going to be your briefest way, right, of getting at the meat of what you're trying to assess in that moment. If you don't have access to that, or not as familiar, or maybe the kiddo is even younger than the age cutoff for the Columbia, you might simply ask, when was the last time you had a thought about this? Or can you tell me a little bit about what those thoughts are telling you? When you have the thought that, you don't want to be alive anymore, can you be more specific? Are you currently having thoughts of killing yourself today or yesterday? Try to get a sense of, the proximity behind how often, how recently these behaviors have occurred, and how frequent the thoughts pop up too. And if you can get a sense of time of day, that's really going to be helpful for you later when you safety plan. Often teenagers will tell me that the thoughts are more prevalent at nighttime when everybody's asleep. Maybe they don't have access to their friend groups as much, and they're kind of just alone with their thoughts. Kiddos who have difficulty sleeping or primary insomnia are going to be at increased risk for this. So once I get a sense of what are the thoughts telling you? When did they last occur? Are you feeling this way today? And how often do they occur? We jump right into intent. So if, the kiddo identifies, yeah, I had the thought last night that I want to die, I don't want to be alive anymore, I might say, okay, well, if we were to send you home today, how likely would it be that you might attempt to end your life? And sometimes I even scale this: 0, not a chance, to 10, absolutely, if someone didn't stop me. If a kiddo is unable to give you a number or give you any insight on intent, we might talk about, well, when you have these thoughts, right, what do you do? How do you cope with that? And then you might get at whether or not a kiddo has done, had any intent, looked up how to end their lives, done any preparation, etc. If you get a sense that the risk is higher and they identify, yeah, I am having that thought about ending my life, you might want to start getting a sense of, has there been any previous attempts? And if you were to go home and end your life, how do you feel about that? What might happen? Just to kind of get a sense of where they're at. Is this more passive suicidal ideation, or is this emerging active suicidal ideation? And then certainly, I ask, what are some of your reasons to stay alive? What are some of the reasons you have that might motivate you to end your life? And this is a great thing to ask about, because this is going to lead us to, when we do our safety plan, our identified triggers or warning signs, right? When these things pop up, we need to be on high alert and immediately start doing our safety plan to help decrease the likelihood that the severity is going to increase, and so we can decrease the chance of suicide. Does anybody have other questions that they use when assessing for safety in a more brief warm handoff situation.
Hey, Jess, this is Cody. I
Yeah.
think one thing, and you might have said it, was for your specific intent question, like if you went home right now, how likely? I also like to add or ask what would make that number go up,
Yes, it's a
just
good
so I
one.
have an idea of, what to look for. So that way, when we're safety planning, we can say, if this event happens, like, I love my partner and I wouldn't do anything because of this relationship I have with them. But if I were to ever lose that person, I would have no reason. And then we make sure that we include that within the safety planning too,
Yeah.
or a big
And
fight, or if I got into trouble.
there's an element that you just said there that I think is important to highlight, and that's immediacy or likelihood that that event will happen, right? And so, Cody, if you identify to me that, man, if me and my partner, were on the urge of splitting, or we got into such a serious, fight that we divorced or something like that, I might say, well, how likely is that going to happen, right? Like, how are you feeling in your relationship right now? And if that's more of an acute thing, right? Like, we fought last night and I got really upset and I got worried versus, yeah, my relationship's on the rocks, right? That's going to kind of maybe change the warning signs. Or if a kiddo's like, yeah, if me and my boyfriend break up, I'm gonna, I'm gonna want to kill myself. Well, how likely is that going to be to happen? Well, we got into a fight last night, but we're doing okay now. Right. And so thinking about how likely is that event, right, to be another trigger before you're able to see them again. And if it's high likelihood, really, like you said, really trying to frame that around safety planning to make sure that we're prioritizing that risk. So this is where if you get a sense, okay, so there's some suicidal ideation, there's some intent here, the risk level is kind of giving you those feelings in your belly, like, okay, this is a kiddo who's at higher risk. Try to get a sense of, have they thought about a plan? Have you had any thought about how you might kill yourself? Have you come close to acting on those thoughts or ever acted on them in the past? And have you taken any steps toward it, right? And so this might include researching things on the internet, gathering items, thinking about and planning, where those items are in my home. It would be important, right, that when you're getting this information, also, assessing for access to lethal means. So things like access to guns, cords, chemicals, cleaners, ropes, et cetera, et cetera. And so do you have access to these things in your home that you would use to hurt yourself? And I always ask about, are there guns in the home? And if yes, right, do you have access to the gun box? Do you know the code or the access key? And that becomes an important follow-up conversation to have with the caregiver in the home as well. It may not always be culturally acceptable or appropriate to ask. How do I put this? The family may not always respond well if you say the guns need to be removed from the home, depending on kind of the cultural values that family may have, how important hunting is to the family, if they're law enforcement, et cetera. But it is important to really have a conversation about limiting access or eliminating access of a minor to those guns if in fact safety is at risk. I always also make sure to go over things like over-the-counter medications and medical boxes as well, because I think a lot of times I found that families kind of underestimate access to things like Tylenol and Benadryl and melatonin. They forget that those could be harmful substances. So I always very bluntly ask if they have access to those things and to remove access to them, open access to them, and make sure the parent's in control if that child needs a dose of any of those medications. Any other thoughts or feels about assessing plan and access to lethal means that come up for you all? So this is looking at, this slide primarily is looking at non-suicidal self-injury. So certainly, suicide and self-injury are not the same things, but I want to screen for it as a risk factor. It also helps me get a sense if that kiddo has access to sharp objects or other things that could potentially cause self-injury that I would also want limited access to while we have a safety plan in place. And then, of course, always assessing for past history is key, because past history is one of the best predictors we have for future behavior. All right, so there's three possible things that we can think about when screening for suicide in a warm handoff. The first, that's in green, is okay. So kiddo may identify passive suicidal ideation, doesn't have a specific plan in place, and has zero intent of following through on a plan, but notes that these thoughts kind of come and go in their mind when they're especially distressed. We might then, with including the parents and part of this plan, send home with a safety plan. Make sure to fill out the safety plan and the coping card with the kiddo in the room with you, or via virtual warm handoff if that's what you're doing. Make sure to discuss all emergency procedures with parent or caregiver. So you may feel that the risk of this kiddo acting on suicide is pretty low. I always discuss emergency procedures because you don't know how transient that state is and if that might go up at any time in between the next time you get to meet that patient. And then try to schedule a follow-up appointment with that with that patient, either the same week or within 1 to 2 weeks if possible. If that's not possible, make sure to schedule some type of phone follow-up with the parent or the kiddo to make sure that, the safety plan you put in place makes sense and make any changes as you need to. If I get the sense that kiddos' plan and intent is kind of somewhere in the middle, or they're reluctant to chat with me, or I'm just getting kind of a wishy-washy feeling, or maybe their intent to follow through is somewhere in the middle, I'm going to offer a same-day crisis evaluation. So this is when, if I have the room available, I'm going to do our full crisis evaluation template, which takes about 40 to 60 minutes to do. That's where I also will then screen for depression and anxiety. I do SIGI caps, and I'm going to look at things like eating and sleep, essentially doing an intake evaluation in addition to that safety crisis evaluation. At that point, at the end of that, we make a disposition. Can the child go home safely with their caregiver, or do we need to consider going to the emergency room for further evaluation or hospitalization? Sometimes, without doing a full crisis evaluation, you can get the sense in a warm handoff that that child's like, I'm feeling suicidal. I looked up last night how to kill myself. Yes, I have access to the means. And if I go home today, I'm probably going to do it. Or the likelihood that I'm going to do it, the risk factors are high in terms of those triggers. Then I may I'm still going to do that coping card and safety plan with the family. But then we're going to talk to the family about getting them to the local hospital for further evaluation and recommendation of hospitalization for that patient. Those of you that do something similar in warm handoffs in your institutions, anything that varies about this process for you all?
I mean, sometimes I think we do a little bit more in this yellow that you said, and sometimes more in the green, but we don't really have a specific protocol that would be the type of evaluation you're talking about. For the yellow part, is that like a standardized thing that you're going through, or is it just a more comprehensive interview than you would typically do, but it's not necessarily like a protocol?
It's both. So it's definitely a more comprehensive interview. I'm definitely asking some finer tuned questions about intent, planning, and plan for follow through. Not only plan and preparation, but plan for follow through. We also tend to go into non-suicidal self-injury a little bit more. We're including a depression evaluation in that and really flushing out those stressors. We do have a standardized template that we use for crisis evaluations. And it should take, anywhere from 30 to 60 minutes to complete. It does have all of the requirements we would need for a 90791, so we can count that as an intake evaluation as well. Here at Geisinger, in order to kind of collect data on crisis evaluations and the outcomes, we did standardize our template, and then we have a research person on our team that collects that data and is able to see, okay, we did a crisis eval and this was the outcome. We also ask about age of the patient and their insurance, so we can see if there's a difference between private and public insurances.
Is there something specific within that protocol that routes you to, sending them home versus inpatient that's a standardized kind of risk stratification tool? Or is it just come down to, okay, now I have more information, now that's just going to inform my clinical decision?
So I think it depends on how you do that evaluation. So I think most of us, we're looking at more data to kind of help inform a clinical judgment. The other thing that we've done is when we include the Columbia, we've created kind of a figure that's this green, yellow, orange, and based on the items that are identified, we're able to kind of stratify that, and it offers us recommendations with how we have it set up. So if certain things are identified, we may say, hey, this is high risk of suicide, might want to consider hospitalization. Not everybody will use the Columbia in their crisis evaluations. So a lot of times it does, I think, come down to clinical judgment based on the increased data that you have. Which is why I don't ever think a crisis warm handoff should ever be a substitution for a same-day crisis evaluation if the risk factors are in fact high. Cody, does that sound pretty consistent
Yeah,
with your
so we
experience?
Yep, we use so we screen with the PHQ-9 as well as the ASQ, and we have a recent publication in pediatrics that showed we actually get incremental value by screening with the ASQ in addition to the 3 questions that are already on the PHQ-9. And then if they screen positive on either of those things, or if the physician just feels concerned about suicide, or that's the patient response, then we give the Columbia and the safety, which is like the larger part of the Columbia evaluation as well. And then risk factors, and then safety planning as well. And this is usually our 3 dispositions as well. And I like to start almost backwards. So we think about what are the 3 dispositions that we could make today, and what is the level of information I need to be comfortable to land in either of those. And I think that helps us when I'm feeling efficient, I think is when I think in that way. When I kind of start with, what are the 3 plans that we're going to end on today, and what information do I need to get there? I'm curious, how often do you land in the green versus the kind of yellowy orange versus the red?
Most of the time I land in the green. I would say, yeah. I almost think about when I think about the numbers, and I'm saying this kind of anecdotally, I don't have them in front of me, but I almost think my school psychology background comes back out, right? I would say like 80 to 90%. When I think of, the 3 tiers to intervention, 80 to 90% probably follow in that green. 10 to 20%, depending on the time of the year, might fall in the yellow. And then a very, maybe no more than 5%, max are really following into that red category. So, and I think there is a difference too when they're coming through for a warm handoff versus when they're coming through for specific crisis evaluation. Because here at Geisinger, we also offer same-day crisis evaluations if a family member calls in as well. So their way to us doesn't have to be through the PCP. So that's kind of a caveat to it as well.
Have you all, I saw where the Columbia came out with like a self-report screener where it's just the 6 questions, but the patient fills it out themselves. And I was wondering if you all have experimented with that at all. It seemed like maybe a relatively efficient way to get some information, maybe even, after the PHQ-9 is given, like the nurse might administer that and then initiate a warm handoff. Or I didn't know if anybody else had seen that or if they were.
We haven't played with that yet here. I know at one point, what we're trying to figure out here at Geisinger, and it was put on, hold, I think, with everything going on with COVID, is but putting together a team that looks at the depression care pathways and assessing for risk, doing the PHQ, the Columbia, the ASQ. Those were all things that we were considering, and we haven't come up with a specific pathway for that yet. But certainly, Matt, if that's something that you guys are starting to play with, let us know how it works out for you.
We haven't used the patient completed Columbia yet, mostly because they already fill out on iPads the PHQ-9, which has the 3, and then the ASQ, which has the 4 plus 1, depending on how they answer. So by the time we go in, they've already kind of filled out 7 items within our flow. And so we use the Columbia to just kind of verify their answers on those, which pretty much tells us which category they're in on the Columbia, and then focus most of the time on the other part of the evaluation, the safety evaluation, like behavioral history and risk factors.
As we're talking, go ahead, Matt, and I'll jump on to something else.
I was just going to say, I was having to give a talk on this to our physicians in a couple of weeks, and one of the things that I came across that was kind of discouraging is just like how not great we are at predicting, which kiddos will go on to have a suicide attempt. And, some of the literature on, that used to be on like risk stratification, maybe, not holding up super well empirically in terms of like, okay, just because we put them in this group is not necessarily associated with whether or not they attempt. And so I think that's difficult, but I think the more we're able to do stuff like that you're talking about and having like a thoughtful way of approaching it and having integrated behavioral health in, I've got to believe that is going to start to turn the tide on some of this. And I feel like we ought to be able to, with the physician, with the BHC, collaborating together, be able to have a better picture than just primary care alone.
Well, and I think along those lines, Matt, I think it's about normalizing the questions, right? I mean, I've often seen the PHQ not get completed, right? Or you have the nurse go, you're not, suicidal, right? Or, feeling really shaky when asking the questions, right? Not feeling confident, which when you do, that those communication styles are going to maybe decrease the likelihood that a person's going to identify like, hey, I'm feeling this way. And so one of the things that we started doing about a year or two ago, for every kid 12 and older, we do the Columbia for our individual visits with the child. And what I tell families when I do that is, hey, we want you to know that this is a safe place to talk about these things. Our job is never to get you in trouble if you're feeling this way, but to work with your caregiver for us to come up with a plan to keep you safe. So I'm going to ask you every time you're here, even if you're here as a picky eater, I'm going to ask you, right? Because in case anything like this ever comes up, I want to make sure that we have an opportunity to talk about it and we have a plan to keep you safe. So normalizing that this is a normal thing to talk about, incorporating it into your regular routine, that, kiddos start to expect it. It doesn't feel as scary. And hopefully, I mean, I don't have the numbers, but hopefully that means we're identifying more people this way.
That's great.
So with that said, let me see here. Like it froze. There it is. Okay. So if the kiddo you feel like falls within the green, there's no imminent safety risk. That's when I want to talk to the family about increasing supervision and monitoring. I want to get a sense, especially over the summer, or if kiddos, are typically home after school by themselves, what is the game plan, right, for these kids? How can they get in contact with someone if they need it? Are they spending time at any other caregiver's home? Even if they fall in the green, but the risk level, right, they're identifying enough where I'm like, hey, we should probably have consistent monitoring for this kiddo. I want to get a sense of, are there other family members we need to include in this plan? And depending on the nature of the situation, that might be, if I have consent to do so, that might be me calling another parent. Let's say kiddo splits home, I might call the other parent and say, hey, here's the game plan. Or I may entrust in that caregiver that's there with me that day to have that conversation with another parent or with grandma or the aunt that takes care of that kiddo after school. I'm always discussing safety planning in the home. So we have coping cards. There are 3x5 index cards that are printed front and back. On one side, it's the safety plan. So it talks about how to restrict access to things like firearms, sharps, substances, medications, etc. On the flip side of that is the coping card that the kiddo fills out. I always make sure that that other caregiver in the home has that safety plan card. I don't fill out the coping kit part, that the kiddo is filling out for the parent typically, but I do have the safety reminders for the parents. On there are also some emergency numbers for the parents to keep in mind in case they are concerned about their child's safety at any point. We also have these translated into Spanish, which is incredibly helpful. I practice in Northeast Pennsylvania, and we have a pretty high Spanish population. So it's really important that if you're giving a coping card to a family member, that they can read it and understand it. So certainly if that's something that would be important for you all to do in your institutions, reaching out to your diversity department and getting hooked up with a translator might be really helpful. I also want to discuss like what would outpatient care look like, right? And so are they interested in coming back short term to see us, to follow up? Do we feel like following up in a couple of days with a phone call would be warranted? If the family's not interested in therapy, sometimes we have kids that are super resistant, or the kiddo already has therapy services in the community, but this came up in the context of a well-child visit, then I might have a plan. I might say, okay, well, I'm going to call you, today's Monday. Let me give you a call on Friday just to make sure everything's going well. And certainly if we have to talk about any follow-up at that point, we can. I always let families know that if the risk were to elevate at any time, that we're available during regular business hours. They can give us a call or they can call their pediatrician for a crisis evaluation. Nights and weekends we're not accessible. And then here are the emergency numbers that they have access to, as well as the county crisis lines. And then I always say, if symptoms were to worsen and you can't get in touch with us, do not hesitate to call 911 or bring your kiddo to the nearest emergency room. So regardless of the level of risk, I always go over all of this with each kid that I'm screening for in terms of safety. This is the safety planning or the coping card part of the safety plan card I was telling you about. This I usually sit with kiddo and write it with them. If they're a teenager, I usually hand them the card and kind of guide them through the questions and they fill it out in their own handwriting. If it's a kiddo who maybe is a little bit younger, sometimes we have kids that are, between that 6 and 12-year-old range. They might not be the best at writing their own card. Then we'll have a conversation and I'll sit next to them and write it with them. If I'm doing this virtually, I do two things. I have the kiddo get a piece of paper and I have them write down these 4 items and have them write it as we're talking. I'm also typing it concurrently in their document. So their note, I should say. So if they have a patient portal, I then send them the safety plan after our visit. If they don't have access to our patient portal, I print this off and I mail a copy home to them. So that way we're kind of making sure we're still going over this aspect of the safety plan card, even if they're not in person with me. So this is just kind of an example of how a kiddo might fill this out, different triggers and warning signs, things that they can do. I always like to include active and passive coping strategies, social and success items when possible. And if a child's identifying that, nighttime is more of a risk factor for them, then I want to make sure they're not putting, talking to friends and playing basketball as their primary coping strategies. I want to make sure that we're putting things on here that they could do at midnight if they're having difficulty sleeping and these thoughts pop into their mind. In terms of contacting people, I want to make sure that these people are over the age of 18. Certainly, it's great to call a friend if you're feeling stressed and overwhelmed, but I want to make sure that there's at least one grown-up listed here. An accessible grown-up. So I'll ask you like, oh, I'm gonna contact my aunt. And I go, where does your aunt live? California. All right, well, we're in Pennsylvania, so that might be kind of hard. Is there somebody that lives with you or is closer to your home that you can contact? Again, we want to contact those people not to get in trouble, but to help keep an eye on us and keep us safe. And then, of course, a plan for where they're going to go if they're feeling overwhelmed to do their coping skills. And I like them to identify what are some of the reasons for living. And then this is the front part of the card that talks about creating a safe environment. I make sure that the caregiver that's with that child has this. And I sometimes provide multiple copies of the card, depending on how many caregivers are responsible for that kiddo's safety. So that's it in a nutshell. Typically, when we're able to do this warm handoff, like Cody said earlier, we are spending anywhere from 10 to 20 minutes. If it feels like I'm having a hard time getting that information in that short amount of time, that is one of my indicators to say maybe we need a full crisis evaluation. And that's when I move into that same day evaluation if possible. All right. Any questions, concerns, thoughts, feels, anything that comes up for you guys?
Hey, Jessica, this is Sarah.
Hey.
Nice job presenting. That's a lot of stuff to go over.
It's a lot of stuff, yeah.
I know, but as I'm thinking about it, in our region, there's actually very few of us doing integrated care right now. And so I'm wondering about your thoughts or other people's thoughts around how much experience have you had training the nursing staff in managing, like when the phone call comes in at 4:30 on a Friday and those situations, 4:55, right? And sort of your perspective about training the other care providers and nurses on the team and such to be managing these situations. What are your thoughts around that?
Absolutely. So I think it depends on the particular clinic. Some staff, and I say this for a couple of reasons. So some of our nursing staff are more transient, right? We have a lot of turnover. Some of our clinic nursing staff have been there forever. Some of our clinics are lucky enough to have a nurse triage person identified. So long story short, to answer your question, yes, absolutely. If you have an identified triage nurse, we definitely talk to them about if you get a call that comes in, please, if we're on site, come get us, right? Either physically come get us, Tiger text us, route that phone call to me in some way, and I can help talk to that parent on the phone if we're trying to assess if that child needs to come in or go right to the emergency room. Where we found difficulty with this, I think, at least my experience in my clinic, is that we don't have a set triage nurse, and it's usually our front office that are getting those calls, not our nurses. At least in our pediatric clinic. And so that's been a little harder. So one of the things that's on my to-do list this year, especially being in and out of the office with COVID and sometimes working virtually and sometimes not, is to help develop a flow chart for those front office staff to follow when trying to figure out how to route them. And again, I think it really depends on it's hard to train everybody because the way our call system works, it's the entire region, which covers about 6 counties. And about 6 pediatric clinics across the Northeast. And so I may not be in one of those clinics, and there might be a front office person answering the phone that doesn't have a BHC in one of those clinics. So it does become a little bit more challenging. But one of the to-do list items on my now that I'm back from maternity leave is to put together a kind of a smart phrase that they can open up in Epic when taking those telephone encounters to help identify, when they need to get somebody on the line with them, or directly sent to the emergency room or to crisis if necessary.
Yeah,
But-
thank you. And you're
Yeah.
right. Like sometimes it doesn't even make it as far as nursing staff. It's,
Yeah.
just kind of reception, whoever's got the phone call, and you just never know who they're going to get. So,
Mhm.
it's a good idea to disseminate the information that way as well.
But I will say from, my experience in other clinics where I'm not now, when the staff are trained, we're more likely to see those kids. I know in a lot of our newer clinics that we're just kind of, shaping up and building up when we're brand new, they're very used to just, oh, safety. Okay, go to the emergency room. And there's very rarely any follow-up questioning. Sometimes the PCP isn't even involved. They might get routed to telephone encounter, but the protocol is, we can't assess that here. If you're suicidal, you have to go to the emergency room. And every once in a while, I still catch that in my clinic where maybe I have somebody who's not as familiar with our services picking up the phone. And when I see something like that, I'm like, whoa, 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 next time, please, get us involved. We're happy to help. Don't put all the weight on your shoulders for figuring out what to do with this family. So. But yeah, definitely room for improvement, I think, across the board when it comes to identifying these kiddos early.
We're just getting started with so we have depression disease managers through a partnership with our ACO Partners for
That's
Kids.
exciting.
Yeah, it's a lifesaver. Like they follow up with them in between appointments, make sure that they attend their follow-up appointments. If they don't, they track them down. They have cell phones that they can text them to make sure that they're getting into their appointments and to just touch base. And one of the things is that when they would call these families, sometimes they would be concerned about risk and crisis. And so we would, oh my gosh, Finn is so cute. We're working on training them up right now on administering it and making follow-up decisions and who to reach out to and working through that workflow right now. So we feel, I think it's a lot to do to make them and you feel competent and confident in the decisions that are being made.
That's really exciting. You're gonna have to keep us posted about how that works, because I know one of the things that are on our magical wish list here at Geisinger with our BHCs is to have our own behavioral health case managers, which we hope would help us, navigate some of those things too. And so, definitely maybe, next year, once you have it up and running, you can give us this is how we do it on having those folks, because I would love one of them.
Yeah, and we're keeping some outcomes and stuff, so we'll be able to keep you guys posted on what that looks like.
That's great.
I'm a little bit curious, Justin, how if Finn can tolerate more conversation. I just saw a yawn. I think I'm boring him already. I would be curious on how you manage those same day evaluations. Is that just one of the situations where it's like, look, this doesn't happen very often, but it blows up my schedule and I'm already 10, 20 minutes into this patient. I'm just going to continue and fill out the rest of that protocol? Is it something that you're like, I have an appointment in 2 hours, come back, or wait in the lobby? How do you usually manage those? Do you have any tips and tricks for when it does cross into that yellow period?
So I think it's a little bit of everything you mentioned. So, part of it is working smarter, not harder. And we start with kind of playing around with our templates. Geisinger has gone through some major templating overhaul in the last 2 years. In fact, we just piloted a new protocol with our templates like a month ago, where we have, we're now doing 40-minute return slots with 20-minute slots for warm handoffs and the nice thing about that is, if let's say I have, a 40-minute return and then I just happen to have, a 20-minute slot after that, that's how I work in the warm handoffs. If I have a kiddo who needs more time than that, I think I do, depending on my schedule and the risk, right? There's been times where I'm like, okay, you know what? I actually don't have an appointment, coming up soon. Right now I'm actually free. Let's just do it right now. Other times, it could be an hour away that I have an intake slot open. I might say, hey, in about an hour, I have, a complete opening. Mom, Dad, do you feel safe keeping an eye on your kiddo? Can you stay here for a few minutes? And, or, go get a bite to eat and come back. I will say I very rarely use that option because I want to catch that kid while they're there, especially if I feel they're in the yellow and need that evaluation. So what I more tend to do is, if I think they're at increased risk, is I tend to kind of let it blow up my schedule. I hope and pray that I have that warm handoff slot and I can make it move. I've even gone as far as, if my next patient's already in the waiting room, just, letting them know, hey, it's going to be a few minutes. We're dealing with an emergency in the back here. Are you comfortable with waiting? Or would you like me to reschedule you? So I try to accommodate all the patients that are there, of course, dividing and conquering and trying to make sure that that kiddo who's the greatest risk is being taken care of. And I also try to utilize my learners. If I see that one of my trainees, right, is being no-showed or has an opening and I don't, sometimes I do a warm handoff to them, and have them do the full crisis evaluation if necessary. Very rarely do I let a kid leave or wait too long to do that full eval.
Cody, could you talk about what caused you all to use the ASQ? And I mean, when I was looking at them, it seemed like there was a lot of overlap between the ASQ and then the CSSRS. And so kind of how you set that up in your system and what the flow is like with that too.
Yeah, for sure. So the decision for the ASQ was kind of above my pay grade. I think the idea was we wanted something quick, efficient that could be used the same across the entire hospital. So patients who are coming into primary care, the ED, behavioral health, everybody's going to get the same screener. We have a lot of content expertise in the ASQ because Jeff Bridge, who's one of the developers of the ASQ, is on faculty, and so we have a lot of flexibility and knowledge about ASQ and different ways that it's been rolled out that way. So the ASQ was selected as something that's been validated as a screener for suicidality and something that's efficient enough that we can apply it across the entire hospital. And then with the acknowledgement that the ASQ doesn't fully break it down into risk categorization or stratification as much as the Columbia does. And so the way that we often end up using the Columbia is more of a compilation of the stuff that we learned from our clinical interview from the PHQ-9 and the ASQ. So rather than going through and asking all of those questions specifically on the Columbia, we kind of take what we know, ask any additional questions we need to know to figure out where they fall in the Columbia, and then spend most of our time doing the risk factors and safety planning for that. So the Columbia is just like a nice way to efficiently document which risk category they fall into based on some of that other information. So it goes PHQ-9 and ASQ in the well visit, and then we follow up with the Columbia as kind of an interview tool to summarize what we learned on those two items, risk stratify, go into risk factors and previous behavior, and then safety planning.
It sounds like your screener EHR system automatically will administer the PHQ-9 ASQ combo. Is that right?
Yeah, we have it programmed into iPads now, which is really convenient. So there's some screeners that they complete on the iPad when they first check in, and that PHQ-9 ASQ are part of those. ASQ was originally designed to be a clinical interview, but that's one of the benefits to working with Jeff is that he was able to adapt it in a way that held true to the initial intention of the interview to have it on an iPad.
Great.
Cody, what did you do during COVID and virtual appointments for things like that, since it was on the iPad?
So for well visits, it was we didn't do that screening typically for those well visits, largely because we didn't really have a good flow for what to do with the positive screens. We also were running back at full capacity very fast. So we were only out of clinics for 2 to 3 months, and then we're back in. Our social workers never left clinic, and either did our PCPs. And so we didn't. And now in telehealth, we do, but we just ask the ASQ verbally.
That sounds pretty consistent with what we did too. We actually have the PHQ is in Epic, and we'll fire for our PCPs, and we can pull it up ourselves if we need to. The Columbia is part of our in Epic, part of our rooming tool, but we didn't have it integrated with we used InTouch as our platform. It was really hard to push that through. So most of the time we would ask those questions verbally and identify it in the medical record. But definitely, I think some food for thought to think about for our ELO is, tips and tricks for assessing safety in the era of COVID, and maybe not being on site with that kid, because certainly that did, there's some war stories, right, that we have about, okay, that kid does identify risk. Well, now they're not in the office with you, they're at home. And for my clinic, they live in a service area that doesn't have a Geisinger hospital. So what do I do? And so I think those are interesting things to think about now that we have to kind of go with the flow when it comes to maybe not being in the office all the time.
That's a great idea. Yeah.
Mm.
And we have a chunky button in Epic. I'm told that's the technical term.
Oh, all right.
But it's a button, like, you have all your like chart review, all the things up top. You click on it and then it has our entire risk assessment built into it. So the Columbia,
Ooh.
the previous, the safety evaluation, so the Columbia screener, and then the safety, which is kind of like the deeper evaluation. And then we have risk factors that, like, for things like older than 13 male, it does pull that into the chart automatically and select that for us. And then for some of the other risk factors, the more transient risk factors, they're buttons for us to click to walk us through the evaluation.
That's awesome.
A place where we kind of put our overall description of summary, low risk, moderate risk, or high risk, and then our safety plans in there too. So all of the stems and everything's created, we just type it in. And then we have smart phrases that pull it into our note or the ABS as needed.
I love that. Now, without going down the rabbit hole that is Epic, was that something that your BHC team built, like worked with Epic build production to make happen? Or was that something that was already being kind of packaged together and used?
Yeah, so it was already created for our whole specialty mental health system. It's part of a larger kind of overview to get everybody on the same page. So our behavioral health leadership had worked with Epic to get it created and to get it standardized across the service line. I mean, we have over 100 psychologists and well over 100 therapists all within our service line. So we're huge, and so we're trying to find out where it makes sense to standardize these procedures and where it doesn't.
That's great. Yeah, I know our Epic builds tend to take what feels like 800 years, but I mean, how lovely would it be? I mean, you know that you've lived the Geisinger Epic way. How wonderful would it be to have a button? So certainly, I might plant that seed and see what happens.
It is nice just to have it built, and then it's tracked, right? So when I pull it up, I just pull forward from my last one and then only adjust what has changed and burn that new change into my note.
That's great.
Which makes it a lot more efficient for follow-up.
Yeah, awesome. Thank you.
And it's also a living document. So, I mean, we can talk about this too, but we're working on our DAs so that it stores it as like hard information, I think, into a flow sheet. So when you update your DA, it's all in there and it's a living document. Or if they transition to a new provider, all of that information is stored within the medical record. So they can pull up the previous DA, update whatever's new, and then burn it into their note, because it's all kind of prefabbed in the note based on these forms. So whether they're seeing psychiatry or us or somebody else or another provider, community behavioral health provider, they start with us and we send them to our mood and anxiety IOP program. When they do their DA, they already have all the information we collected in ours in a way that, like, they don't have to look it up and retype it into their DA. It's already in a form that can just be updated within the form and then pulled into their note.
That's great. That's really great. I feel like that's a CFHA presentation in and of itself. It's just how to get that workflow utilized consistently.
Yeah, agreed. Well, this was fantastic, Jess. Thank you so much. It was really good content. I think it was really helpful to think through what this looks like also in real life. Like, how do you adapt your schedule? How do you make this happen in 10 to 15 minutes? And when do you decide to make it just take the full hour? Seeing Finn was definitely the highlight for me of the presentation.
He's laughing at his grandma right now.
I was gonna say that is such a sweet smile. So Sarah, I know I'm not sure if you've seen our other This Is How We Do It, but we'd love to hear from you sometime too. This is a very novel This Is How We Do It. Usually it's a 5 to 10 minute presentation where people give a very brief overview of your model. Basically, how do you do things where you're at? It's just 5 or 10 minutes. Courtney, same thing. If you guys are ever interested, we'd love to hear from you guys, just to hear about what your guys' models look like where you're at. 5 to 10 minutes, and you can also include anything that you would like help with as well. So kind of lessons learned or things that you're thinking through as far as next steps. So let us know if you're ever interested in doing that. we would love to hear from you, just to understand, you know, how people are making this work in different ways across the country. 5 to 10 minutes, but we'll give you 20, 30, 40 if you want it. We did not get to our research corner today, or our planned facilitated discussion, but I think it was good that we paused and really spent some time talking about crisis evaluations, buttoning that up with some real world examples about how they do it out at Geisinger. So we'll pick up on our research corner and our facilitated discussion at our next session. Anybody else have any last minute parting thoughts before we get off here? No? All right. Well, I really appreciate you guys all taking time on your Monday to spend time with us. And seriously, Jess, thanks. That was super helpful. I'm like furiously writing notes about things. Yeah, for sure. All right, y'all. We'll see you next month.
Bye, everybody.
Bye.
Everyone.